Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. September is Blood Cancer Awareness Month. Blood cancer doesn't always get the attention of other cancers, even though every 9 minutes, someone in the U.S. dies from blood cancer. While treatment has advanced greatly over the years, increasing survival rates, there is still a long way to go. So today, we're talking about blood cancer, its advancements in treatment with Dr. Ashkan Emadi, Physician-in-Chief of Medical Oncology at the WVU Cancer Institute. Welcome, Dr. Emadi, to Live Healthy West Virginia.
Thank you for having me.
It's great to have you here. So, it's Blood Cancer Awareness Month, so I want to start with, let's talk about what are the different types of blood cancer?
That's a great question. So the answer to this question depends on what level of the detection we have, right?
Okay.
So if you have, let's say, a microscope that you can define the blood cancer just based on their shape, we will have probably a couple of hundreds types of blood cancer. However, with the advancement of the genetics and some of the DNA recognition that we know in different blood cancers, so we now identify blood cancer based on the genetic characteristics of them.
Okay.
So based on that, we may have several hundreds of blood cancers. But for the audience, in general, blood cancers, we divide them into 3 big categories.
Okay.
One of them are leukemias, which the cancer cells, they are circulating in the blood. And they often originate from the bone marrow, which is this space that inside our bones, that some of the stem cells that they grow there. The second part, there are, as I said, several hundreds types of leukemias that these days we call them. Some of them are more acute and aggressive. Some of them are more chronic, right? The second big group of blood cancers are lymphomas. So these are the blood cancers that generally originates in some of the lymph node. We have them around our neck. We have them, up here in the shoulder area. We have it under our armpits. So they can start from, or sometimes inside our abdomen or inside our chest wall cavity. So they can start the cancer cells in the lymph node and they spread different ways. Generally, we call this, probably you heard about the Hodgkin disease. Yes. Or Hodgkin lymphoma. That's a small, probably 10% of the lymphomas are Hodgkin, and then there are a lot of non-Hodgkin lymphomas. So that's the second group. The third group are, we call them myelomas or plasma cell disorders. What are plasma cells? These are the very mature cells. Remember about COVID, people are talking about the IgG and antibody,
Yes.
So these are the cells that they generate antibody. And when they become cancerous, there is a group of blood cancers, we call them plasma cell disorders or otherwise myelomas, different stages of myelomas. Then, in addition to these 3 big categories that under each of them you have several hundred types, right?
Yeah.
You have some of the very rare types that you probably cannot put them on each of these categories, but they are very rare.
Okay, good to know, good to know. In general, are blood cancers hereditary?
There are the very minority of blood cancer, again, in that leukemia and lymphoma, myeloma pattern that we said. Mm-hmm. There are some families that we see, for example, the grandfather had multiple myeloma, now the son has it, and then kind of the third generation also has it. We don't know what is the pattern of inheritance, but they are not by far common. Okay. So I would say in approximation, probably about 5 to 10% of blood cancer are hereditary.
Okay.
Otherwise, most of them happens what we call them as an acquired disease through different environmental or lifestyle that might happen, or some of the time, in about probably 3/4 of the time, 75%, we don't know why this blood cancer happened. So we put the name as a fancy name. We call them de novo, which means that I have no idea what is the etiology or risk factor
Why this happened.
of this blood cancer.
All right, good to know. So what are the general symptoms and signs of a blood cancer?
So remember, I told you that most of these blood cancers are leukemias and particularly myelomas.
Yeah.
They originate from the bone marrow. So if these cancer cells keep growing inside the bone marrow physically, they don't let the good stem cells to grow inside the bone marrow, physically and chemically, because they generate some compounds that suppresses the good cells. So the three major things that can happen, the red blood cells, which we call it as the hemoglobin, is going to be low. So people become anemic. When you are anemic, the oxygen carrying capacity from your lung to your muscle to your heart is decreasing because you don't have enough of the, so to speak, taxi driver to carry oxygen from your lung to the tissue. So people that they are anemic, particularly the anemia become more aggressive and more profound, they feel fatigue. They are tired all the time. If the anemia gets worse, people may have shortness of breath. They become short-winded. People sometimes may have a chest pain. So these are the symptoms of anemia. The second group of symptoms that can happen because of these cancer cells, the white blood cells might be low. So what are the white blood cells? White blood cells are like military, right? So you have Navy, you have Army, you have different branches. We put the different name, neutrophil, lymphocyte, monocyte. There are different types of white blood cells. When they are low, your body is prone to have infections. Your immune system will be low. What type of infection? Bacterial infection. People may get sinusitis. People may get a skin infection. People may get pneumonia that doesn't get better. They are viral infections. There are fungal infection, and there are some other opportunistic infection that people might be prone when they do have this blood cancer. So the first one was red blood cells. The second one, white blood cells. The third group is lower level of platelets. Oh, wow. We call them thrombocytopenia. That's a fancy name we put it in. What are these platelets? Platelets are these little cells that they're circulating in our blood, and when we cut ourselves, it helps us stop bleeding. When your platelet count is low, or not, God forbid, not you, the person that has a blood cancer, they are at increased risk of bleeding and bruising. What are these bleeding and bruising manifest? As a nosebleed. People may have gum bleeding or gum swelling. People may have blood in their urine. People may have blood in their gastrointestinal tract. They may see blood while they have a bowel movement. People may have little dots of the bleeding under their skin. So these are different types of bleeding that can happen because of the low platelets. So these are the general signs and symptoms. In addition to that, sometimes people with blood cancer, particularly the lymphoma, they may manifest as a drenching night sweats. I've had patients that they're coming and saying that, Dr. Emadi, I have to change my pajama like 3 times per night. People may have some unintentional weight loss, like you eat well, you feel that your appetite is good, and the person keep losing weight, essentially. So these are some of the general signs and symptoms. And again, for each of those specific types of blood cancer, there might be a specific signs and symptoms. For example, sometimes people may have a horrible bony pain. Sometimes they may have a pathological fracture without bumping to somewhere, one of the bones get fractured. But these are by far is a general signs and symptoms of blood cancers.
I know that early detection is always a good thing. But these kind of symptoms, this sounds like, is it hard to detect blood cancers in general early on?
So that's a great question. The issue is that, as you mentioned, blood cancers are not very common, right? They're not as common as lung cancer or breast cancer. So a lot of these symptoms are common and non-specific symptoms, right? So some people may have a little bit of viral infection, and because of that, they have, being fatigued, they have night sweats, they have like their immune system is low. And a lot of people that they may have some of these vague symptoms, they get better by their own. But if these symptoms persist, let's say for 3 to 4 weeks, and you have some enlarged lymph node, excuse me, that doesn't go away with antibiotics, and it's kind of keep growing, that is sometimes, need paying attention. For similar to any other cancers, for like leukemias, we don't stage them because blood goes everywhere, right? So these leukemias are only cancers that we don't stage. But by far, if you catch lymphomas as a stage 1 or 2, the prognosis is better, the treatment is less cumbersome, and the outcome of the patients are better. So if some of these symptoms persist for more than 3 to 4 weeks, despite doing the common things, you go to your primary care physician, get antibiotic, get vitamin, do this, and they keep getting worse, then you must, seek more medical attention, probably from a specialist or being referred by your primary care physician.
Sure. So who would you say is most at risk for developing a blood cancer?
As I told you, that blood cancer, a lot of the time when I sit down with my patients, there's no reason for that, right? So the first thing happens, the first question, like someone is perfectly fine today, and all of a sudden they go to their primary care and their white blood cell count normal is between 4,000 to 11,000 per microliter of your blood. Now all of a sudden their white blood cell count is 100,000. And they are told that they're diagnosed with acute leukemia. And they come to me, and the first question is, why me? I was perfectly fine until yesterday, what did I do wrong? I tell you a few rare and exceptional things, but by far, my job is in that first day that the patient, the family are devastated.
Sure. Oh,
and blood cancers in general are very aggressive. Without treatment, the survival of most of the blood cancers will be in the matter of a few weeks to a few months without treatment.
Wow.
My job is to tell them that this is just the bad luck. I'm here to help you and help your family. We are gonna fight this. A lot of blood cancer are treatable, more than 99% of them. A significant portion of them are curable.
Wow.
But you need an expertise in those, right? So I don't treat lung cancer, breast cancer, prostate cancer. I'm very specialized in blood cancer, and even within that blood cancer, in leukemia, and within leukemias, probably more in acute leukemias. This is a very rare disease. It's about less than 30,000 people per year in the United States are diagnosed with acute leukemia. My job is to tell them that it's treatable, it's curable, you haven't done anything wrong, you were not a bad person for God, you didn't break your husband or wife's heart, you didn't eat anything wrong, so it's not immediate thing. So that's by far, the assurance is very important.
Oh, I'll bet, yeah.
Very small portion of blood cancers, I told you that they have some genes that make them congenital or hereditary. They are very rare, right?
Okay.
And not every person that has those genes, they get their blood cancer. They just having an increased probability of having the blood cancer.
Okay.
But one portion that is very important, I see as a leukemia doctor every week, every month in my clinic, the patients that they were diagnosed with other cancers, breast cancer, colon cancer, lymphomas, another, one of the type of blood cancers, prostate cancer, they get a radiation. Because of the chemotherapy or radiation therapy that they appropriately received and they cured them from their first cancer, unfortunately, those chemotherapy and radiation, they are damaging to the stem cells in the bone marrow.
Oh,
So
wow.
a proportion of my patients, we call them therapy-related or treatment-related acute leukemia, right?
Right.
So these are the people that they already cured from one cancer because of chemotherapy radiation. But those chemotherapy radiation damaged the stem cells. Now they have the leukemia cells, right? It's very incredibly difficult to treat these patients because those cells, they already seen chemotherapy.
Yeah.
This is not the usual conventional chemotherapy is not going to help you. There
Right.
are, fortunately, I hope that we get into that. There are different aspects that we can attack this. There are different
let's talk
ways.
about that.
Okay.
Let's talk about the treatments, because there have been some major advancements in treatments in the last 2 or 3 decades. Tell me about, let's talk about the good stuff.
Good stuff. Okay. So let's do organized way, right? So
Okay.
I tell you that probably about more than 3 decades ago, then when I went into medical school, there is a very a small portion of acute myeloid leukemia, which is very rare disease. It's my area of specialty. About 21,000 people per year in the United States are diagnosed with that. 10% of people with acute leukemia, they have this subtype of acute leukemia. We call them APL, which stands for acute promyelocytic leukemia. When I was there, more than probably 80% of the people universally die of this cancer within like 2 weeks of diagnosis. And those deaths was horrible. All of us were scarred. People bleed from every orifice from their body.
That was 30 years ago.
Yes,
talking.
I
Okay.
tell you that. Right now, we cure. Mary, cure is not like remission. Cure, I have a plethora of patients from when I was in University of Maryland or at Johns Hopkins that this APL is their past medical history. 12 years ago, they're diagnosed with this. How we cure them. This is the cure rate is better than probably you have a strep throat and I give you penicillin. With what? With 2 drugs that they're not even chemotherapy. High dose vitamin A, we call them Atra, and low dose rat poison, arsenic trioxide. For
And
this is
it cures that particular cancer.
correct. 97%
So you went from 80%.
death rate in
Death
2
rate.
weeks to 97% cure rate, right?
Wow.
Exactly.
That's
Let's talk
huge.
about it's huge. Let's talk about other type of AMLs, non-APL.
Okay.
For 5 decades, we had probably 2 class of regular chemotherapy to treat AML. We were curing probably 10 to 15, 20% of the cases. I tell you that since 2017 until now, we have 11 different drugs that they are approved for AML. 9 of those 11, they're oral chemotherapy. And this is based on the genetic. Remember at the beginning, I told you that depends on how deep we go in the genetic of the cancer. The
Right.
cancer can be more specific. Based on each of the genetic characteristics of those cancer, there is a drug that if the cancer occurs because of these changes, and if my drugs switch off this, the cancer cells die.
Wow.
So we had a huge advancement in AML and With the bone marrow transplantation or a stem cell transplantation, we offer cure for some of the worst leukemias. Remember those therapy related?
Yeah.
They are still curable with eventuality of the bone marrow transplantation.
Wow, that is good news.
It is great news.
That's very good news.
Let's come to another type of acute leukemia, ALL, acute lymphoblastic leukemia, which is much more common in children.
Yeah.
Our pediatric oncology colleague cures more than 85% of children with ALL. We as an adult medical oncologist, we cure a significant proportion of these patients. And since 2013, there are 4 immunotherapy class of the compounds, including the cellular therapy that we have available for ALL.
Wow.
Let's look at another one of the leukemia I'm talking about.
Yeah.
Chronic myeloid leukemia, CML, which is the poster child of what we're calling it targeted therapy. The first time ever that we found what is the cause of CML. Just little DNA change, chromosome change was 1960. Within 40 years, from 1960 to 2000, not only we discovered the cause of this, the mechanism of its causing cancer, and how to attack that, some of the molecular aspects of this. In 2000, the first targeted therapy for all cancer, the name was imatinib, was approved. That has revolutionized treatment of CML. Each year in the United States, there are 5,000 people are diagnosed with CML. Before the invent of this imatinib, there are now 6 other drugs such that, right? Half of those people die per year. Now, people don't die of CML. CML is truly a chronic disease. As long as a person take 1 or 2 tablets a day, similar, you have a high blood pressure. Can somebody cure high blood pressure? No.
But you can control it.
You can control it. In 2050 onward, in the United States, there are going to be 250,000 people, 250,000 of people that they live, they work, they're happy with CML, as long as a person take 1 or 2 tablets, right?
Yeah, that's great. That's great. This
Do you
is
want me
all
to
good news.
continue? Let me continue.
Well, okay, one more,
Okay.
because I want to get to this other stuff too. So you can tell me about one more.
So I'm still on leukemia. I haven't gone to lymphoma, which we cure a significant proportion. 80% of Hodgkin lymphoma, we cure them. 65% of non-Hodgkin lymphoma, we cure them. Multiple myeloma was a devastating disease. Multiple myeloma is now truly a chronic disease. We have people, when I was in Maryland, actually, we had some celebration of people that they lived 15 years with multiple myeloma. These things, when I was in medical school, or even at fellowship at Hopkins, these things were a dream. The last one on leukemia, let's finish leukemia.
Okay.
Chronic lymphocytic leukemia, CLL, is a disease of elderly, right? We had no cure for it. There was, the chemotherapy that we offered. These are the older people that, because they're aged and they have some comorbidities, lung issue, heart issue, you cannot give them the chemotherapy. CLL is truly a chronic disease with drugs that they're not even chemotherapy.
Oh, wow.
They're oral targeted therapy.
Like
Why?
blood pressure medicine.
Exactly. Why all of this happened, Mary?
Well, yeah, let's talk a little bit about that, because I wanted to talk a little bit about the research you do, because you told me in an email that one of your goals is to change the standard of care for blood cancer patients in West Virginia, the United States, and on planet Earth. Okay?
That's correct.
So tell me about that. What is the focus of your research? How are you making that happen?
So before I talk about myself, National Cancer Institute, when it was started in 60s, there were outstanding physician scientists that they went to NCI, National Cancer Institute, and each of them from NCI, they went to different big cancer centers and cancer institute. And not only they were taking care of the patient, which is, I love it. Like my Monday clinic is fully blocked. I'm the department chair of medical oncology, but on Monday, everyone knows that they shouldn't bother me with anything because I'm dedicated to my patients, right? So we care for these patients. As I told you that they didn't do anything wrong to have this horrible disease. But it's not enough, because if this was not because of those people, that I'm very proud that I stand on the shoulders of these giants. And United States in the world gets a big lion's share of these clinician scientists, right? I stand on the shoulder of those. I have been mentored by those. My mentor from Hopkins, Dr. Karp, Dr. Rob Brodsky, Dr. Ed Sosville. I can name so many people that when I'm talking about my lab and what I do, I learn from them.
Okay.
And I try to implement those things that I learned from them, add to them, and pass the baton to the next generation of the scientists.
So what are you focusing on as you do this?
My lab is focused on the targeting amino acid metabolism for cancers, not only blood cancers. Amino acids are the building block of proteins. This is probably oversimplification, but there are some cancers that they are addicted to these amino acids as their supply, as their food.
Okay.
So my lab is specifically focused on the glutamine, which is the most abundant amino acid in our plasma, in our blood, focusing on targeting glutamine metabolism and glutamine depletion for different variety of cancer. For example, that AML that I told you, we know that is addicted to glutamine. Just before I come in here in February 2024, I had an investigator-initiated clinical trial at the University of Maryland combining 2 novel drugs to treat patients with AML that literally had no other option except for hospice, and it's provided significant remission rate and hope for some patients, right?
More good stuff.
More good stuff.
Yeah.
So glutamine, I am collaborating with some of the scientists here at Neuroscience Institute, Rockefeller Neuroscience Institute, to target, because we know that different parts of brain tumors, they are addicted to glutamines. We are collaborating with Dr. Brian Boone because some portion of the pancreatic cancer, which is a devastating disease, is addicted to glutamine. So how we target this and how we advance this forward is very important. In my lab, we hired 2 extremely smart PhD scientists, cancer biologists that came from University of Maryland here, and they are working on some of these things in the lab. I'm very, very excited. I carve out, again, Mondays, I'm in the clinic, but I carve out making sure that, I spend time in the lab. And when I go home, my second or third job starts, and that is when I start typing the manuscript, editing the previous manuscript that came back from journal. So this is the love of the work of love, that you have to, and until we invest both time, finance, financial, manpower in the basic and translational science, things will not advance. The medical oncology in 2024 is totally different, even in 1994, even in 2004.
Wow. You have to keep looking for answers. And when you're talking about, working with the Rockefeller Neuroscience Institute and other, doctors in the Cancer Institute, finding cures for cancer is definitely a team sport. So I want you to talk about the team at the WVU Cancer Institute and how deep the expertise is at the WVU Cancer Institute.
That's another great question. So I tell my son, who is actually want to be an MD, PhD, is that the people that they can advance the field the most are the people that they combine 2 or 3 disciplines together, right? I'm a blood cancer doctor focusing on the glutamine targeting. My knowledge about how the brain works and the brain cancer is not that great. So I collaborate with people that they are expert in this. You know, you collaborate with the statisticians and people that they are good in analyzing very complicated data, because a lot of these experiments that you do, the outcome of this is like huge. Like you need to like see that how I can see the forest and not being, you know, lost in the trees. Like you need to collaborate with different disciplines and different scientists, including that a statistician and bioinformatician. One thing that, you know, we have in the medical oncology department, we have 3 divisions. 2 of them are kind of traditional divisions. The third one that I created in Department of Medical Oncology, I'm calling it Division of Cancer Support. Who are these people in that division? These are oncocardiologists. These are cardiologists.
Oh, wow.
That focus on heart failure, because what we do with all of those chemotherapy, as great as they are, we can damage some of those chemotherapy, the heart. When I was in fellowship or medical school, there was only one class, the name was anthracyclines, that they can cause the heart failure, right? Now, this immunotherapy that the revolutionized treatment of lung cancer, treatment of, you know, the GI cancer, the gastrointestinal cancer, different, they can actually cause a significant damage to your heart in some proportion of patients. The drugs that we treat, you know, myeloma, they can damage the heart. Some of the drugs that they are very useful for women with a specific type of breast cancer, we call them HER2 new positive breast cancer. There are 6 or 7 drugs targeting that, you know, pathway. They can actually damage your heart. So it's not only, I'm not a cardiologist, but if I collaborate with a cardiologist that has an interest in patients with cancer and get expertise in that, then we all can grow better, and they can offer some clinical trial how we can prevent or treat some of these cardiac issues, heart issues. What's the next one? We do have a new onconeurologist. A lot of chemotherapy that we give to the patients, they're damaging the nerve. People will have numbness, tingling, people that in their arm, in their legs, they have difficulty walking. So there's a neurologist that specializes in this chemotherapy-induced neuropathy, which is the nerve damage. We have oncopsychiatrists. Cancer is a devastating disease. It's not easy to be told that you have cancer and you put clock on people's life. And through that route, even to cure, it's gonna be 2 months, 3 months, 6 months, 9 months. People cannot work. People cannot provide for their family. People, they have to be admitted to the hospital. If you are not affected by that, being anxious, being depressed, having low mood, or having all sorts of thinking, I think that it's abnormal, right? So you need an oncopsychiatrist. These are the psychiatrists that they focus of taking care of the cancer patients.
So the treatment is definitely a team sport, and it sounds like we have a very deep bench in a lot of different specialties when it comes to treating cancer.
You bet.
So,
particularly here in WVU.
At WVU Medicine, and a very deep bench, obviously, which is good to know. Like I always say, it's right here in our front yard. You know, you don't have to leave the state to get this kind of treatment.
That's correct.
It's right here in our front yard. So before we go, I always like to ask, what's the most important thing you want people that are watching or listening to this, what's the most important thing you want people to know about blood cancer and blood cancer treatment?
The most important thing is that for the majority of people, they didn't do anything wrong to get these cancers. The second thing is that blood cancers are one of the most curable. You mentioned that, can we find a cure for cancer? In any gathering that I go, people say, have we found cure for cancer? Hopefully by now we know that cancer is not one disease. There are close to probably 7,000 different types of cancer. And we have cured for a significant portion, particularly in blood cancer. So if you have a blood cancer, A, it's not your fault. B, depends on what blood cancer you have. There are a lot of treatable and curable options available to you. And 3, for people of West Virginia, here in Morgantown, I'm very, very proud. Again, I'm here for about 6 months. I'm very proud of our team of the blood cancer doctors. We are the only place in the state of West Virginia that we offer bone marrow transplantation to our patients. We offer very novel cellular therapy to our patients. The same drug that you can get in Houston, you can get in New York, you can get in Chicago, we offer the same thing here. And we have a fantastic social workers, as I told you, that psychiatrists, neurologists, cardiologists, palliative care to take care of the different aspects of this. This is a teamwork. And one thing that you said, people, what I want them to know, don't be sorry, don't be guilty. Seek help and seek a specialist, because I am a board certified medical oncologist, but I don't treat prostate cancer, right? So seek a specialist, because now the literature is so vast, one person hardly can cover all of those. So you pick up one very narrow field, but you go deep down. My finger is on the pulse of 4 or 5 prominent blood cancer journals weekly. Every week I review those to see what are the new advances. I get some idea, what can I do it in my lab? What can I bring it here? What can we do this? So blood cancer, a lot of blood cancer are curable, or they are truly a chronic disease as long as people taking 1 or 2 tablets a day.
Curable or manageable?
Yes.
All right, good to know.
Easily manageable.
Easily manageable, even better.
Yes.
That's great. Thank you so much
for
sharing all this good information with us. You've given us a lot of hope, and I think that's always a good thing.
That's a true hope. The second or third things that I tell my patients, I never sell false hope. The patient deserves to know the reality is my job to bring that complex understanding to the level that patient can understand. And I help them to make it the best decision. I tell them that I never practice paternalistic medicine. I tell the patient, I'm your servant. My job is to offer you the best option and help you to make a decision.
Okay.
And this is a true hope. It's not a false hope.
Excellent. Thank you so much. I really appreciate it.
My pleasure.
Well, that brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information about blood cancer and other cancers, visit wvumedicine.org/cancer. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast or on the all-new West Virginia Metro News TV app. I'm Mary Ravazio Menard, and on behalf of Dr. Emadi and everyone at WVU Medicine, thanks for joining us.